Welcome back, everyone. Hope everyone had a good break. Our first session this afternoon is presented by Professor Amanda Woodward from Michigan State University School of Social Work. Professor Woodward and the MSU School of Social Work have partnered with our foundation on a study to improve the understanding of the mesothelioma caregivers' experience from the time their loved one is diagnosed through the patient's death and beyond. This study was awarded grant funding by the Department of Defense Congressionally Directed Medical Research Program. Welcome, Professor Woodward, to show us what's next in this study.
Good afternoon, everybody. I got the dreaded after lunch spot, so I will try and keep you awake. You remember that, I don't know if it was Sesame Street, the electric company, that little bit they would do of like, one of these things is not like the other? Yeah, I remember. I feel like that a little bit with this study. You've had the tumor panels and the clinical trials, and now we're going to look at a qualitative study based on qualitative interviews of caregiving. So shifting gears a little bit. I do want to say a few thank yous. Jen and Linda are doctoral students in our social work program at MSU who are instrumental in implementing this project. Of course, Julie mentioned that this is in partnership with the foundation. But of course, patients, caregivers, bereaved, those of you who have shared your stories with us, been very generous with your time and trusting us with your stories and sometimes difficult conversations. This would not be possible without you. So thank you very much. As Julie mentioned, this is funded through the DoD, Yay Advocacy. This is the mechanism that Melissa mentioned that advocacy got Meso onto the grant. So that's where this support for this comes from. I'm going to very quickly go through an overview of the project. The full project, because I want to spend the bulk of the time talking about what we've learned so far from the first phase of this study, and then a little bit about what the next steps are and opportunities for you to be involved in that part of the project. So as we said, this is a partnership with the foundation, and it partly emerged out of the survey that the foundation did in 2021 of the Mesothelioma Foundation community, and the need for improved support for caregivers and bereaved folks sort of emerged from that. But there's just not a lot about caregiving in the context of mesothelioma in the US. And there's even less on the transition from caregiving to bereavement. So there's a gap in the research and a need expressed in the foundation community. So our ultimate goal is to develop and test an online caregiving support intervention. But we're really taking a community-engaged approach to doing that, which means that we could put together an intervention and test it, but we really want that intervention to be centered in the lived experiences of the community. And so these first two phases are really learning from you guys about what this experience is like, and then using that to shape an intervention that will hopefully be effective for folks. So there's 3 phases. It's a 4-year grant. There's 3 phases. We just finished phase 1, which I will be talking about in a little bit more depth. And we are starting phase 2, actively recruiting for focus groups and for key informant interviews. And again, I'll say a little bit more about that toward the end. Years 3 and 4, then we will actually implement an intervention, or I should say the foundation will implement an intervention, and we will collect data on it to test the feasibility of the intervention and see if it's something that we could then scale up and test further. All right, so phase 1, the goal for this first part of this project was really to better understand the caregiver experience. And we set out to do 20 to 30 interviews. We ended up interviewing 27 folks between December 2024 and May 2025. That included 5 patients, 12 caregivers, and 10 bereaved. And those interviews lasted on average about an hour. And these are the topics that we covered. So we covered quite a lot in that time that we spent with people. We talked about the process of getting the diagnosis, the treatment journey, what was it like to give care and support and to receive support, What type of support did caregivers receive throughout this? Or if they didn't, what was missing? What would have been helpful? How did this impact relationships between patient and caregiver, but also with other people as well? What was most difficult for folks? Did they have conversations about end of life with their loved one? And if so, how did that happen? What facilitated it? What was that like? If not, what were the barriers to that? And with the bereaved folks, we talked about the death of their loved one and really the last weeks, days, hours of life, what that experience was like and what kinds of support they had through that, and what was missing. A little bit about the folks we interviewed. So the median time since diagnosis at the time of interview was 3 years. For the bereaved, it had been on average about 1.5 years since the death of their loved one. The average age of patients was about 56. Caregivers were a little bit younger than that, and you can see that there was a wider age range for caregivers and bereaved as well. Most of the folks we talked to were women. 3 patients were women, 3 men were caregivers. I like to highlight that because it is sort of outside of what we see as the sort of stereotype, right, or what we see in a lot of the literature. We also had, in terms of race ethnicity, a more diverse group than we often see or think of in the realm of mesothelioma. Most folks had a plural diagnosis. Most received chemo and or immunotherapy. 11 people had surgery and 8 also had radiation. And the folks we talked to came from 14 states, so you can see how it's distributed here with a mix of mostly urban and suburban geographic areas. So I'm not going to go into too much nitty-gritty in terms of how we analyze the data, but the key things for what I want to share today is this mapping piece. So as we talk to people about the process of getting the diagnosis and the treatment journey, we did that chronologically, and to the extent we could, we really tried to pin down dates when things happened, and then we, for each person, mapped out this timeline of how this experience unfolded. And then we can overlay other themes that come out of the interviews on top of that timeline. And our goal is to figure out kind of what are the most sticky spots in here, right? Where are the places that are hardest for people? And what kind of help did they get that was useful? What were the impacts of those? And where were there, at what points were there things missing that we could maybe provide support? So the results from today are from 22 interviews, partly because there's still a couple that we're working on in terms of mapping, and then there were a few just because of the nature of the conversation. It was hard to sort of get the timeline, and those interviews contributed to overall themes, but we don't have clear mapping for those. Okay, so I'm going to talk about first some of the patterns that emerged from that mapping process, and these are sort of the 4 points along the way that I'm going to talk about: onset, diagnosis, treatment, end of life. These are overall patterns that we're seeing in the data, and so I just want to highlight that, again, this is a qualitative study. I'm not attributing any causal links to anything here. But they are patterns that are emerging from these conversations. So in terms of onset, there were sort of 2 buckets that people fell into. One was a sudden onset. So there was an event like severe pain, severe difficulty breathing, something that led the individual to the ER and escalated very quickly, often led to a hospital admission, and then from there to diagnosis. The other group was a much slower process where there was some sort of ongoing issue, persistent issue, maybe a constellation of symptoms like pain, fatigue, difficulty breathing. Sometimes they were attributed to other things. So for women in particular, it's menopause, or it's your period. So they were kind of ignored. They led to people going more to their primary care for help. Sometimes they were looking for help for something else, and the mesothelioma emerged out of the process of getting help for something else. So it was a slower process to sort of, in terms of what led to them seeking medical care. Again, there were sort of two groups then for diagnosis as well. There was a group that got a diagnosis really quick. Once they sought help, they had a diagnosis within 3 months was the outside. For most folks, it was quicker than that. And then there was a group that it was more delayed. It was longer than 6 months. Those were folks where it was often like initial tests came back negative, or it was misdiagnosed as something else, or there were a lot of comorbidities that made it more complicated to sort of figure out what was going on. And this is where the point at which, I'm like, there's no cause, I'm not attributing causality here, but most of the folks in our interviews, if they had a quick diagnosis, they were in that sudden onset group. So most of the folks who had sudden onset ended up having a quick diagnosis, and most of those folks had a plural diagnosis. In fact, almost all. In the more slow onset group, it was a little bit more mixed, but there were a higher proportion of those folks who ended up with a delayed diagnosis. And it was more mixed in terms of what the diagnosis was. The time from diagnosis to treatment was pretty quick for most people. In those cases where it was a little bit slower, the folks that we interviewed, those were folks who had surgery as first treatment. And again, there was sort of a pattern that emerged here in terms of folks who had a quick diagnosis. Almost all of them had chemo and or immunotherapy, some combination of those two. And there were folks in that group that had surgery and radiation too, but they were a smaller proportion. And again, it was more mixed for the sort of slow onset, delayed diagnosis pathway, where about half or a little over half had chemo, and then it was sort of evenly distributed in terms of what other types of treatment they might have had. In terms of end of life, there was no clear pattern related to whether it was a sudden or slow onset or a quick or delayed diagnosis or what type of treatment people had. And of the 22 interviews that this mapping is based on, eight of those were with folks who had lost someone. Pretty much everybody in that group, they received some sort of palliative care or hospice care. But again, two sort of pathways emerged at this point. And so for some folks, again, there was some sort of event. They had AFib, they had a really high heart rate, something that sent them to the ER and they were hospitalized. And then from there, went into hospice. And in most of those cases, it was sort of about a month from kind of that event until end of life. And then the other group, it was more gradual. The treatment stopped working, or the goals of care changed so that they moved to focusing on pain management as opposed to aggressive treatment. And folks were kind of in that realm from anywhere from 1 to 8 months. And then from there, moved to hospice. And we're in hospice from like 2 to 5 months before end of life. So in each of these sort of time points, at least diagnosis, treatment, and end of life, we've pulled from the interviews some of the things, as I said, that kind of emerged as things that people found helpful or things that they felt like they needed. And at the diagnosis stage, information was what people needed. They needed, as one person said, they need clarity about the landscape of the situation. And people talked about going online as like first stop. Whether it was search engines or social media, they went Googling to figure out what mesothelioma is and what's going on. People talked about the challenges of evaluating the quality of what they found online, and also the pros and cons of those online searches. A number of people talked about like just having to stop because it was very overwhelming, and what they were learning was pretty grim, and it was hard to process. People talked about the Meso Foundation and how helpful the foundation was in terms of the people, the website, the symposium. But not everybody found the foundation this early in the process. So this is a subset of folks who, were lucky enough to find the foundation pretty quickly. But there were other folks who didn't find them either at all or much later in the process. Some folks talked about accessing research studies, so going to the NIH and learning about mesothelioma that way, and then a lot of people talked about word of mouth. In terms of the types of information that people wanted, prognosis was one, but it was mixed. Like some people wanted a prognosis and some didn't. And sometimes there were instances where the caregiver wanted prognosis information, but the patient didn't. And it was frustrating for the caregivers because the doctors were not going to give them that information outside of conversations with the patient. And pretty much everybody wanted some sort of personal stories, connections with people who have experienced what they're going through to sort of learn what's happening and what to expect. Across all of these time points that I'm talking about, social factors emerged as things that sort of really differentiated people and the speed with which they got diagnosis and where they got treatment and how they navigate this journey. And so at the diagnosis stage, these social factors really influenced access to information. So these included things like health and digital literacy. So how familiar are you with the health system and how it works or doesn't work, as the case may be, and how digitally savvy are you? Like, do you know where to look for information and evaluate it? The access to and ability to understand research was important sort of distinguishing factor here. Having time and resources, which is often tied to socioeconomic status. Some people, had sort of just more time and resources to put into researching and finding information and doing that kind of thing. Connections came up a lot at this stage. There were some folks who had family or friends who were in healthcare or in kind of research settings, didn't know anything about mesothelioma, but they knew where to go and who to ask and how to find the information. And the sort of experience between those folks and folks who did not have those connections was pretty dramatic. At the treatment stage, of course, information is still important, but this is where people really started to talk about the need for emotional support and financial support. So information about treatment options, of course, was important. People talked about how it often wasn't clear, and sometimes also that there were limited choices. So there wasn't really a decision to make. It was just, this is what we got to do. Information about where to get treatment, information about clinical trials, those came up. In terms of support, this is where caregivers started talking about support groups with other caregivers and the importance of having those connections and being able to connect with people who are going through similar things and at our different stages along the journey. And communication from healthcare providers came up here too, and we heard stories from sort of both ends of the spectrum. So, you had your grade A panels up here, or the people where the surgeon sat down with them for 2 hours and talked through everything with them and talked about all the different options and the pros and cons and how to make some of these choices. And on the other end, well, I got my 15 minutes and then, never heard from them again and couldn't get them to respond to my phone calls, and then everything in between. So having good communication and empathic communication from healthcare providers really came out a lot here. In terms of social factors, the ability to pay for treatment, of course, came up. If you are a candidate for surgery, but you can't pay for the surgery, it kind of doesn't matter. The ability as a caregiver to sort of take time off work or, have a flexible job or be able to work at home or have a lot of time banked so that you can go to appointments and do those kinds of things came up. Location. So are you near a cancer center with a meso specialist or have the ability to travel to get care or ability to travel to NIH or that you're reasonably located, that it's easy to get to? Folks who were not located in those places and didn't have the resources to travel had different experiences. Age and life stage showed up here, and I think this came up in some of the panels where in terms around decision making around care, right, and what treatment plans are. So if people had kids at home, if they have a career, if the patient themselves is a caregiver for others, all of these things came into play in terms of the decisions that people make about treatment. And then health literacy came up here too, and in this case it was less about accessing information and more about the ability and the willingness to advocate and to push back and to question healthcare professionals, so to push for a second opinion, and to dig if you don't get the answers that you're looking for, to kind of keep pushing at it. And some people have more ability to do that than others, and that really differentiated people's experience. And then social networks, that was the other big one. So if you are a caregiver and it's you alone versus you have a group of people kind of surrounding you who can help carry some of the load, that really made a difference in terms of people's experience through the treatment journey. Information and support, of course, were big at the end of life as well. In this case, the types of information were around how to find in-home care or hospice care. Some people talked about sort of being told, at the hospital, we can't do anything more for you. It's time for hospice care. And then kind of crickets. And so the folks then having to figure out, okay, what does that mean? How do I find hospice care? I don't even know quite what hospice care is. How do I do this? Also information about what to expect at end of life. So ideally hospice helps with that, but some providers are better at it than others. So, how long does my loved one have left? What can I expect at the end of life? How do I know the end of life is approaching? What kind of care can I be expected to provide at end of life? How to have conversations about planning for the end of life came up as well. It came up at multiple parts of the discussion, but particularly as people were approaching end of life. Those are difficult conversations to have, and so, trying to figure out what do we need to talk about, how do we talk about it, when do we talk about it, those kinds of things. And people were looking for information and help around that. Grief support, of course, is important, but what came up, I think, most strikingly was the questions about the best timing for grief support. So, immediately after death, there's a lot of people usually around. You've got the funeral, people kind of come and help, and then they go off to their own lives, and you're still left there as you've still lost your person. You're still there trying to figure out how to do that, how to move on to the next phase of your life. And so the place where maybe support is missing is a little further past the death of your loved one. And I didn't put it here in terms of social factors, but sort of age and stage of life came up here around grief support. So some of the younger folks talked about, going to a grief support group at their church, but it was mostly older folks who lost a spouse, and it was really hard to kind of relate to them as a younger person. So age and life stage kind of comes into play here as well. Ability to pay for hospice came in as a social factor. Connections came into play here as well, in terms of, again, if you know somebody who is part of the healthcare system and can help you figure out where to access hospice and what you might expect at the end of life. And then health literacy in terms of advocating and so forth, and your social network. Those things differentiated some of the experiences at end of life pretty dramatically as well. And then across the whole range of experiences, there were some things that are, I'm sure, no surprise to anybody in this room in terms of the uniqueness of mesothelioma and how that influenced the experience. The rarity of the disease limits the community of like people. So folks talked about going to a general cancer support group, for example, which is helpful up to a point, but there are enough differences that it was not as useful as it could have been. Some folks talked about how it complicated interactions with healthcare, and not necessarily the mesothelioma specific healthcare, but kind of the ancillary care that goes around that. So somebody went to their doctor, they go to the ER because they have a fever, and the folks in the ER see mesothelioma on the chart and are like, whoa, we don't know what to do with you. And the patient and the caregiver are kind of having to educate them. It's like, no, we have a fever. We need help with the fever. And that kind of being an ongoing complication that people were encountering. Of course, the ongoing uncertainty of living with mesothelioma and kind of going from scan to scan. The legal piece of mesothelioma, which is different from other cancer experiences. And questions about exposure. So sometimes it was clear, sometimes it wasn't. People were worried about, their families also being exposed and other questions around exposure that sort of make this a unique experience. So what are we going to do with what we've learned so far? I just gave you sort of a slice of what we've learned. Our next step is to build on this to develop an intervention, like I said, that we will then test further on. So right now we are recruiting for focus groups and key informant interviews. The focus groups, we have patient caregiver groups and a bereaved group, and each of those groups will have 2 sessions, and that QR code there takes you to a screener survey. So if you are interested in participating, you can finish that survey, fill out that survey. This first session will be a version of what I've presented today, a little more targeted version where we'll share some of what we learned and get people's feedback and do you see yourself in this, what we've shared? Are we missing something? Is there more context that we should have? And then really talking specifically about some of those points along the way and what support people received that was helpful and why, and what was missing and what might have been more helpful. And we will use that to draft the intervention, and then session 2, we will bring that draft of intervention to the folks in the focus group to get feedback. And then the key informant interviews, I don't know if there's any health professionals or legal folks left in the room, but we're doing interviews with health professionals, again, to kind of get their reaction to what we've learned and learn more about what they perceive as patient and system level challenges. And then with the legal professionals to talk about sort of what's the typical legal process and what they see as most challenging for patients and caregivers. And I think we have time for some questions, yeah?
We can take a couple questions. Anyone has one?
I always find that we're missing the people who have no support, people who are single and alone. What do they do? And have you looked into that at all?
So we did have some folks in the sample who were they were the lone caregiver, caring for a parent, for example. We didn't have any patients who did not have any support, if that's what you mean. So all of the patients that we interviewed had somebody. And the bulk of who we interviewed were caregivers or bereaved. But we did have some caregivers who were in it pretty much alone. And they struggle a lot, yeah. There's a lot of, and most of those folks tended to be a little bit lower socioeconomic status, so they are working, right? They can't necessarily afford in-home help. They are trying to pull together finances from a range of sources. So yeah, it's definitely a struggle for those who are in it alone. Informal support is clearly really important through this.
Hi, this is the kind of thing I would be willing to participate in, but I'm not media savvy. I don't know what a QR code is. I don't have a smartphone. Is there any paper documentation that I could fill out or complete or have somebody call me or something like that?
Well, so we could do the screening survey that way. We could call you and complete the screener survey. I will say the focus groups are on Zoom, so you would have to access them by Zoom on the computer. But let me give you my card, and we can connect and see about at least getting you into the screener part, right? Yep. Okay. As long as you can get on Zoom, then you can get in the focus groups. That's cool.